HealthEd is Australia's leading provider of quality clinical education for doctors and other healthcare professionals. This episode has been made available on Spotify and Apple Podcasts. For free access to the full library of podcasts and to claim CPD for listening, visit healthed.com.au or download the HealthEd app.
Today my guest is Dr. Sean Copson, and we're going to be talking about the management of endometriosis, with a particular focus on management in a primary care setting. I particularly wanted to discuss some of the newer medications that are now available for the up to 1 in 7 Australian women diagnosed with endometriosis. Dr. Copson is a specialist gynaecologist and an accredited laparoscopic surgeon. His particular clinical interests are endometriosis, pelvic pain, menstrual disorders, and complex laparoscopic surgery. Sean is a graduate of the University of Western Australia. He currently holds a public appointment as a specialist gynaecologist at the King Edward Memorial Hospital. He's passionate about endometriosis research and is currently working with researchers from the University of Western Australia in an attempt to reduce delays in the diagnosis of endometriosis and also to develop a more holistic treatment approach. The focus of both Sean's clinical and research work is an acknowledgement that it's only by listening to women and involving them closely in the management of their pelvic pain, heavy bleeding, or endometriosis that we can maximise the quality of their life after their diagnosis. Hello, Sean, and welcome to today's HealthEd Women's Health podcast.
Hi, lovely to be here.
Now, Sean, the federal government demonstrated a huge commitment to women's health issues just before the last election, go figure. And thankfully, some of that focus was on endometriosis, a condition that affects up to 1 in 7 Australian women. And I think we both agree it was about time for such a spotlight, given that in the past many Australian women have simply suffered in silence. But before we get on to endometriosis, Sean, and the importance of the primary care practitioner, its diagnosis and its management, can I ask you how you came to develop your interest in this condition?
Yeah, so going into obstetrics and gynecology, I was massive for the obstetrics. That's all I wanted to do. And then started doing more of the general gynecology and got into the surgical management. And I work in our only tertiary referral unit for the whole of WA for endometriosis. And I just found it was an incredibly under-resourced area and under-researched as well. And it really sparked my interest, I suppose, the gender inequalities we have for how common it is as a condition and how under-recognised it was before and how much scope there is to improve the standard of care. So it just really interested me, and most of my practice now is just managing endometriosis, which, I love doing. It's a difficult condition to manage. But yeah, it's been excellent, as you were saying, very exciting, the areas that the government's been improving in the last few years, and there's a lot of scope to improve things further.
Thanks, Sean. Seeing as our focus here, I guess, is general practice, what do you see as some of the key challenges that GPs face in recognising and diagnosing endometriosis in a primary care setting?
Yeah, it's a great question. Look, some of the key challenges just relate to patients even presenting in the first place with with the symptoms. So we know that the symptoms of endometriosis can be very non-specific. So the more common symptoms we talk about are dysmenorrhea or painful periods, but it really does range from non-specific symptoms such as bowel issues such as diarrhea and constipation. Fatigue or exhaustion is a massive one, nausea and vomiting around the time of their period, fertility issues, pain on passing urine, pain on defecating. There's such a wide range of symptoms. So recognising, it's easy if someone comes to see me, I'm a gynaecologist, I just look with my gynaecology hat on. But to look from a general practitioner side of things with these non-specific symptoms can be quite difficult. The other thing, for a number of years, and I see patients all the time that unfortunately they feel that their symptoms have been ignored. So I'm not just talking about in the health setting, I'm talking about in the home life. They get told that, their mum had painful periods, therefore it's normal. And those people will never make an appointment to see a GP to discuss their painful periods because they've been told that this is just a normal occurrence. So I suppose the key challenge in the small amount of time that you have as a GP specialist in seeing a patient is to nut out, do they have any gynecological issues, which they might not present as in the first place. That's probably not the reason they're making that appointment unless it gets to the point where it's really severe. So part of it, and I think what we should be doing for screening for all patients is much like contraception. Anyone who's between the ages of started to get their period, so 12 years old through to the age of 50, which should be an automatic screening question, is do you have any menstrual issues at all? Do you get severely painful periods? And screening for those common questions. But it can be a challenge with the time constraints of working in a general practice setting for sure.
Sean, I hit the Endo Australia website last night and I was cheered up to learn that the delay in diagnosis is down from something like 8 to 10 years to about 6.5. So I guess that's an achievement. But can you speak to the importance of early diagnosis and intervention in reducing disease progression and improving the woman's quality of life?
Yeah, for sure. So, I mean, as you were speaking with Louise Hull the other week, like having a diagnosis is therapy, really. It's being able to say, this is the condition, this is what it causes. And it just opens up to have access for all that extra support, but all the extra information as well. But solely looking at endometriosis as a pathological condition, we do know that if you leave a lot of things that cause pain, if you leave them undiagnosed or untreated, then that can result in a cumulative pain burden. So we know that people, if they suffer from pelvic pain or dysmenorrhea without treatment and recurrent pain occurring every month, and the scarring and inflammation that occurs from endometriosis, they can develop what's called neuropathic pain. And I describe this to patients as where their nerves in the pelvis start firing off pain signals when something might not be there causing the pain anymore. So even after any surgical treatment or other treatment, they still get ongoing pain, or they become predisposed to chronic pain syndromes. And that's usually due to central sensitization. So their brain, instead of becoming tolerant to that pain response, that area in their pain actually magnifies that pain response. And that can occur if we leave anything that causes ongoing pain, if we leave it untreated. So early diagnosis and intervention is incredibly important. From a fertility side of things, it's really important to get a picture early on. I mean, unfortunately, I see a lot of women who have just kind of put up with painful periods a lot of their life. They get to the time when they want to try for a family and they try for the 12 months, and then they see a fertility clinic and they're going through all this workup and only find out that they have endometriosis at that point. Whereas I think we can be a lot more proactive if that's the case. I advise women, if they know they've got endometriosis, they should seek intervention if they haven't fallen pregnant after 6 months of trying. So really, it helps you be proactive with family planning as well. But also, probably most important is validating the patient experience. So often you speak to these women that have waited whether it's 10 or now 6 years that they've waited for a diagnosis. And the main thing is that they felt ignored by our health sector and they disengage from that. They have worsening mental health outcomes as well. And so trying to get that early diagnosis and intervention can definitely improve mental health outcomes and engagement in the health system. And that has ongoing downstream benefits for the rest of their life.
Thanks, Sean. So let's talk specifics. What are some of the red flags or symptom patterns that might prompt earlier referral to a gynaecologist or to an endo specialist?
Look, anyone who experiences severe pain with their periods that's not settling with simple measures, so not settling with hormonal suppression, so hormonal contraceptives, or isn't settling with non-steroidal anti-inflammatories if they can take that. So severe pain if they're needing time off school, if they're needing time off work, I think that should prompt an earlier review. We'll talk about kind of the options for empirical treatment, and it's important to do that. But if they've started that empirical treatment and the simple measures aren't working, then earlier review is necessary. There are some red flags where patients need more immediate review. So signs of severe disease, including ovarian endometriomas. So if you do an ultrasound, and any basic ultrasound should be able to pick up an endometrioma in the ovary, which is a collection of endometriosis. An endometrioma bigger than 4 centimetres has a slightly higher risk of malignancy. It is only in the range of around 1%, but that's at that immediate risk, and that would prompt more immediate review. Or if there's signs of any other severe complications of endometriosis, so any ureteric obstruction, any severe bowel issues as well, or subfertility. So if they have symptoms suggestive of endometriosis and they haven't fallen pregnant after 6 months of trying, then that should prompt an earlier review. But basically anyone where they've tried these basic simple measures like anti-inflammatories or hormonal contraceptives, and if they're still getting persistent pain, that should prompt referral to a gynaecologist or endometriosis specialist.
Thanks, Sean. I'm glad you brought up ultrasound because I was going to ask you about the role and I guess the limitations of ultrasound and other forms of imaging in diagnosing endometriosis.
Yeah, look, ultrasound has come a long way and it's a fantastic tool to diagnose endometriosis, as is MRI. And the benefit of ultrasound over MRI is that it's cheaper for the health system and more easily accessible. I suppose the difficulties with ultrasound is it's very operator dependent. So I can see a patient who's had a generic pelvic ultrasound, usually done at a practice where they do a wide range of scanning, so musculoskeletal scans, as well as gynecological scans and other things with a normal scan. And they just often don't have that specific level of training to look for endometriosis. They'll comment on the size of the ovaries and the uterus. Compared to a specialist women's imaging or a sonologist who's done their O&G training and has done some extra training on top of that, where they'll look at the mobility of the ovaries, they'll have a look at the uterosacral ligaments, which are a common spot for deposits of endometriosis. And ultrasound is really, really good at looking up for signs of severe disease, even more so than an MRI for looking at things like the uterosacral ligaments or for looking at bowel mobility. And an ultrasound, if they pick up and say there's signs of severe endometriosis, that has a specificity of about 98%. So very, very, very specific to say, look, this is severe disease. It's always important to remember for any of these imaging modalities that a normal ultrasound or MRI does not exclude endometriosis. So upward of 30% of people with a normal ultrasound, and that's a normal ultrasound done by an expert, they can still have endometriosis as well. So the role of ultrasound, I think these days, is to look for severe disease. From my side of things, severe disease really matters if they're considering surgery, because endometriosis is about their symptoms and their pain. If they have pain and they have an ultrasound that is normal or an ultrasound that shows deep infiltrating endometriosis with uterosacral nodules, if they're going to manage with hormonal therapy, it's not that it doesn't matter if they have severe endometriosis, but it doesn't change their outcomes at all. Where ultrasound really comes into play is assessing what their surgical risks are as well, and assessing if there's any bowel involvement for surgical management. The limitations we've said is, the limitation is that if there's superficial endometriosis, that usually won't be detected on an ultrasound or an MRI as well. So while they've come a long way, they're not perfect. They're also, the main benefit of that imaging is to look for a differential diagnosis. So does the patient have adenomyosis that could be causing their symptoms? Do they have an ovarian cyst that could be causing pain? Are there signs of inflammatory bowel disease that could be explaining some of their symptoms as well?
Sean, there are also specialised ultrasounds, aren't there, to investigate deep infiltrating endometriosis, particularly in the posterior area of the pelvis. Can you tell us when you might refer someone for one of those? Because I believe they require bowel prep and they can be a bit more expensive.
Yeah, look, a deep infiltrating endometriosis ultrasound, that really is the gold standard of imaging for diagnosing severe endometriosis. Not everyone needs one. We usually say if it's not going to affect the patient's management, they usually don't need that extent of an ultrasound scan. So when I would send someone for a deep infiltrating endometriosis scan, if they have signs on a standard pelvic ultrasound which make them more likely to have what's called DIE, or deep infiltrating endometriosis. So for example, if someone has an endometrioma, a collection in the ovary, the data would show us that 60% of those patients also have other deep infiltrating endometriosis. So if you're ever going to consider doing surgery for someone with an endometrioma, they should all have a deep infiltrating endometriosis scan. Because what we don't what you really want to avoid for these patients is you want to avoid them having unnecessary surgical procedures. So your worst case is someone who has an inadequate workup, goes in and has a laparoscopy and has what we used to call a peek and shriek surgery, where they have a look, do a laparoscopy, say, actually, this is more severe than I thought, close up, send them to an endometriosis specialist who is adequate, has the training to deal with that extent of disease. So it's really having that preoperative workup before. So anyone with an endometrioma, I would do a deep infiltrating endometriosis scan for. Anyone who on a pelvic ultrasound where they've looked at the uterosacral ligaments and they've already seen deep infiltrating endometriosis, but they might not have had good views of the bowel to comment on mobility or if there's a bowel nodule involved, then I'll send them for a DIE ultrasound. Or if they've ever had previous extensive endometriosis surgery before, then I'll send them for a DIE scan as well. But aside from that, I mean, in the realm of primary care, I think a pelvic ultrasound done by a specialist centre who's a women's imaging centre, a pelvic ultrasound should be completely adequate.
Thanks, Sean. I'm glad you mentioned surgery because it's a beautiful segue into my next question. I was wondering if you could share your thoughts on the shift away from diagnostic laparoscopy as the gold standard for diagnosis and the implications of that shift for primary care physicians.
Great question. And look, it's been mentioned recently in guidelines, which has been interesting because for those of us who do a lot of endometriosis, we haven't used the term diagnostic laparoscopy or used laparoscopy for diagnosis of endometriosis for quite a while. With the build-up of the excellence in imaging with ultrasound and MRI, often you can use ultrasound or MRI as a diagnostic tool. And as I said, because of the really high specificity, especially of ultrasound findings, if that shows signs of endometriosis, there's your diagnosis there. A laparoscopy should be reserved for treatment because we know laparoscopy can be very effective for managing pain symptoms associated with endometriosis. So the goal of doing a laparoscopy should be suspecting there's endometriosis, going in to treat the disease. We're moving away from saying, patients have to have a diagnosis before we start talking about treatment options. So as a GP specialist, if you're seeing someone in your rooms and if you suspect they might have endometriosis based on their symptoms, and again, there's no symptoms that you could say they definitely do or don't have endometriosis, but you suspect it, they have period pain, which seems quite severe, they get dyspareunia or pain with intercourse, they have dysuria, pain at other times of their cycle, then you can say probable endometriosis and you can start empirical treatment. So they don't need a laparoscopy to confirm that. And even with the ultrasound, as we said, about 30% of cases will have a normal scan. You can still say they have suspected endometriosis and we'll start medical treatment to see if we can improve their symptoms. So start non-steroidal anti-inflammatory drugs, have a chat with them about using hormonal suppression with the combined oral contraceptive pill, progesterone-only pills, Mirena IUDs, that type of thing, to reduce the delay in them accessing treatment. And a large proportion of patients, about 70%, will get significant symptom improvement on hormonal treatment and will not need laparoscopic surgery to confirm the diagnosis. And yes, technically it will always be a question mark. It'll be possible endometriosis, but for the purpose of instituting treatment, that's enough at the moment to say, look, you could have endometriosis, let's start treating it. And if you don't have endometriosis, you have adenomyosis or primary dysmenorrhea, severe period pain, and those are managed by medical treatments anyway.
Sean, with regard to surgery, one of my favourite gynecologists has a saying, do it once and do it well. Is that a fair statement of the current position?
Yeah, for sure. Yeah, your ideal patients, if they're going to have surgery, so either they don't have surgery and they manage with medical treatment, and that shouldn't mean delaying surgery for patients whose preference it is that they have that as first line or who have tried other medical treatments. But if they are going to have surgery, have one procedure. So have it ideally done by someone who's trained to manage the extent of endometriosis seen on the scan, adequate preoperative workup with really good quality imaging, with the goal to go in and treat all of the endometriosis in one go.
Thanks, Sean. And that brings us neatly to my next question, which is, what are the different surgical options for endo and when are they indicated?
So it usually depends on the patient's stage in their life, their desire for having a family, or like for family planning, or if they want more children in the future, that's usually the determinant. The surgical options are, well, laparoscopy should be done for endometriosis. Patients for endometriosis should never really have a laparotomy or open surgery. So laparoscopic treatment of endometriosis. So you hear in the literature people talk about two options: ablation, which is vaporization of the tissue using diathermy, or excision, so cutting out of the lesions. And there's a lot of online material where patients from blogs, etc., will talk about excisional surgeons. And I think that's the patient's way of identifying someone who's done an extra level of surgical training to do that. And that's how they identify them, as an excisional surgeon. But what the data would actually say is there's been a few randomized control trials done for early stage endometriosis, stage 1 or stage 2. And the outcomes seem to be the same between the two, ablation and excision. The benefit of excision is you have a pathology diagnosis to send. If you have deep infiltrating endometriosis, you know that you've excised the whole lesion. Whereas with ablation, you don't know how low or how deep that diathermy effect is going, and we don't know if you've excised the whole lesion and what scarring's left behind. So from a laparoscopic treatment, you can ablate the lesions, but most people these days would excise them so that they know that it's been removed in its entirety. Your other options for surgical management are things like a laparoscopic hysterectomy to do at the same time. So just to reiterate, a hysterectomy does not cure endometriosis. There is no cure for endometriosis, unfortunately. What a hysterectomy does is, if they have associated things like adenomyosis, so endometrial-like tissue kind of trapped in the myometrium or muscle layer of the uterus, and that can cause heavy and painful periods, that will concomitantly treat that at the same time. And it's been shown to reduce the reoperation rate, so reduce the need for surgery in the future, because it is a bit more effective at treating pain than laparoscopy alone, but obviously their family needs to be complete. And generally, a hysterectomy is done with removal of the fallopian tubes, because about 20% of ovarian cancer is thought to come from the tubes, and you reduce that risk significantly. The ovaries are generally left behind, because we know if you take the ovaries out, they'll go straight into surgical menopause, and there's significant risks involved with that. So osteoporosis, heart disease, cognitive decline, lots of things. So we generally leave the ovaries. But in some situations, I would remove both the ovaries. So in a patient who's had recurrences of endometriomas, in a patient who's got really severe disease, where that surgical procedure is really high risk, or any future surgical procedure is especially high risk, then I might counsel them about removing the ovaries at the time, because we know that the chance of a recurrence of endometriosis with the ovaries removed is significantly lower than if they're left behind. And then they always have the option for hormone replacement therapy to reduce the vasomotor symptoms that come with removing the ovaries.
Thanks, Sean. That's a great summary of the options for our patients.
This episode is one of hundreds of informative and free clinical podcasts from Health Ed. Access the entire library through the Health Ed app for healthcare professionals, which you can download today from the App Store.
Can I ask you, what are the outcomes that patients and their GPs, I guess, should expect from surgery in terms of pain reduction? And what do you do if the pain recurs down the track?
Yeah, it's a really good question. And it's what I counsel all my patients before is the most important thing with this is expectations. So much as we counsel a patient about a surgical procedure and the risks of infection, bleeding, damage to other structures in the pelvis, we should also be counseling the patients about what the expected pain improvement outcomes are before they're having their surgery. And that really allows them to make an educated decision about what is best for them. Unfortunately, we can have a lot of patients who they have a surgery, it doesn't improve their pain, and then they're at a complete loss because they didn't realize that was an option. Or they go in for surgery and there's no endometriosis there, and then they don't know what to do. So the expected things, and what I would always speak with my patients beforehand, before booking surgery, is to say, look, surgery can significantly improve the pain you experience with endometriosis, and that's in the realm of 70 to 80% of patients experience a significant improvement. And that does mean 20 to 30% of patients, unfortunately, they have laparoscopic surgery, have all of the endometriosis removed, and their pain is unchanged. And there's a small portion of patients where surgery worsens their pain, and that's in the range of about 1 to 2% for the general person. In someone who's had multiple surgical procedures or has other chronic pain syndromes or predispositions such as previous significant trauma, or other conditions such as regional pain syndrome or fibromyalgia, that can go upward from 2% to 5% or so. So that generally I would tell all of my patients before booking for a procedure that that's what the outcomes are. Why would that surgery not improve their pain? So it might be that while they do have endometriosis, that's not the cause of their pain in their first place, and chronic pelvic pain can be quite complicated. Or more commonly, they have a downstream problem of endometriosis. So the neuropathic pain that we spoke about before has become an issue, and you can excise or cut out the endometriosis lesions, but that nerve damage in the pelvis has still occurred. Or their pain has become hypersensitive to pain, have developed central sensitization. And those are the patients that still might have persistent pain, or any surgery can flare up those nerves and increase their pain as well. Or if patients have muscular issues, so myofascial pain, and the most common one is a overactive or hypertonic pelvic floor. And often almost diagnostic of this is if the patient presents and said they have pain with intercourse and an aching pain afterwards, then as far as I'm concerned, that's diagnostic of a hypertonic pelvic floor, and they should see a women's health physio. And women's health physios worth their weight in gold for managing of myofascial pain and overactive pelvic floor to try and optimize their pain outcomes. The patient who has persistent pain after surgery, I mean, they're always tricky to manage, and the most important thing is multidisciplinary management of these patients. So as a GP specialist, that should be really central to that care of the patient with them going through that path together. There's lots of different strategies they can utilize. So a gynaecologist who specializes in endometriosis to say, look, you've had surgical treatment. Is there any scope to optimize your medical treatment, hormonal treatment, or some of the newer GnRH analogs to manage that? A pain specialist should be integral to that as well, especially a pain specialist who specializes in women's health. A physiotherapist we spoke about as well. A psychologist, not because they're pains in their head at all, but because chronic pelvic pain can be debilitating for people's mental health. And all of these other supportive measures. There's a lot of great online programs as well. There's other additional things like seeing a dietitian to talk about a low FODMAP diet. Things like acupuncture, mindfulness, meditation can help as well. So you really want to be part of a multidisciplinary team for those patients who have persistent pain despite surgical treatment.
You mentioned fertility before. So what are the most important messages that a GP can convey to a woman with known endometriosis who's trying to conceive?
Yeah, it's, the first step is recognizing that endometriosis could be contributing to fertility issues. So we know that endometriosis can cause scarring in the pelvis. We know that it can cause inflammation, and that creates a suboptimal environment for fertilization and implantation to occur. And the inflammation from endometriosis can be detriment to oocyte quality as well. So I think just recognizing that it could be contributing. Equally important is recognizing that it isn't the only factor that could be contributing. So in anyone with known endometriosis, I usually say, look, try naturally to conceive for 6 months. And that would be different to advice for someone else to try for 12 months, because we know endometriosis is more likely to be contributing. As a GP, you should still do the workup to exclude other causes of subfertility. So still get their partner to do a semen analysis, and still check if they're ovulating and if they want to do a tracking cycle. A pelvic ultrasound to exclude any uterine structural abnormality, which could be impeding things. Whether you assess fallopian tube patency, that's a bit more in depth because it depends kind of what their next step is, I suppose, because it's quite an invasive thing to do. And if they go on and do something like IVF, where there's no need to check tubal patency, then they might not do quite an invasive investigation. But really having kind of that low threshold to further investigate for other contributing factors. But definitely if they've been trying for 6 months with known endometriosis, then referring them either a fertility clinic or a gynaecologist who specialises in endometriosis, because we know it depends who you speak to, and this changes quite a bit, but the chances of falling pregnant each month with endometriosis is significantly lower than the general population. Depending on the staging of the disease would show you how beneficial or not beneficial surgery would be. But if they have superficial or early stage endometriosis, surgery can improve their chances of falling pregnant naturally. So they might consider a referral to a gynaecologist who specialises in that surgery. But that should also involve counselling, that if they ultimately do go down the path of assisted reproductive technology, surgery might not necessarily improve those outcomes, and therefore you don't want them to have an invasive laparoscopic procedure if it's not going to improve their chances of things like IVF as well.
Sean, with regards to medical management, where do the newer hormonal treatments like Gynaecologist fit into the current treatment landscape?
Yeah, it's incredibly exciting that we've had some new treatment options out there, and it's, I suppose, more exciting that the government's have come to the table and offered a more significant rebate for patients with that being on the PBS. Gynaecologist, or the class of medication, is by no means new. We've been using GnRH, or gonadotropin-releasing hormone analogues, for a number of years. We've been using Zoladex. So where Zoladex differs is it's an injection. They need to have it initially every month, and then once they have it for 6 months monthly, they do qualify for the 3-monthly dose. And so what it does, it's basically, it works along the hypothalamus pituitary axis, and it blocks the signal of gonadotropin-releasing hormones. So Zoladex, the implant, binds to those receptors and saturates them first, so they can get a flare of that pain about 7 days after starting, and then completely suppresses the hormone release of follicle-stimulating hormone and luteinizing hormone that acts on the ovaries, and essentially puts a woman into menopause. That's how it works so well. Gynaecologist, similar class of medication. It's a GnRH agonist, so it binds selectively to those receptors. The benefit is it does not cause that initial flare 7 days after starting. The other benefit is it comes in tablet form, so they just take a tablet every day, much like the pill. They don't have to worry about injections every month or every 3 months. And it also, the main side effect people report about is those menopausal side effects, so vasomotor symptoms such as hot flushes. So Gynaecologist comes with a little bit of hormone replacement therapy as what we call an add-back treatment, which is what we used to do with Zoladex. We used to use something called tibolone as well, which has similar properties. So it helps reduces those side effects. And it's really just made it more accessible. You take a daily tablet and it's a lot cheaper than it used to be. It definitely has a select patient group that you would use it on, because it works by putting patients essentially into menopause. So you're not going to do this for everyone, but it's where it fits in, I believe, is these patients who have tried multiple more conservative treatment options before, like the pill, or they've had laparoscopic surgery and they still have persistent pain, or patients whose potential surgery or repeat surgery is likely to be very high risk. So they've got signs of severe deep infiltrating endometriosis with bowel nodules or bowel collections, and they're not keen on going ahead with surgical management because they're concerned about the risks. Then a treatment like Gynaecologist definitely is fantastic for those patients, and they get really good pain outcomes with it. But they need to have close monitoring of their bone mineral density in particular to make sure they're not developing osteopenia or osteoporosis while on this treatment.
So just to clarify, Sean, Gynaecologist can be prescribed by GPs as well as by specialists?
Yeah, so there's no restriction on who prescribes Gynaecologist. It can be prescribed by a GP specialist or a gynecologist. I think because it's quite an in-depth conversation and understanding what the minute risks are and the benefits, I think realistically, and it might be down the line that this becomes a lot more common and mainstream where we have really set guidelines in place. But I think at the moment, what would usually happen is the initial prescription of Gynaecologist would be conducted by a gynecologist and someone who specialises in endometriosis management. And then a clear management plan, as should always be portrayed to the GP specialist, to say, look, this is the treatment I've started on. And then if the GP is comfortable, they would continue to provide prescriptions for that medication and monitor the patient's bone mineral density with yearly scans as well. It might come, we get to the point that a lot more people are more comfortable with its use. The indications are clearer for the type of patient that would be taking it, and GPs would start this prescription. But I think at the moment, realistically, it would be a gynaecologist who starts the prescription and the conversation. And if the GP is comfortable to provide those ongoing prescriptions and reviews of the bone mineral density, then they would do that going forward.
And Sean, a question out of left field, I hope you don't mind. Is it contraceptive? Is Rayco contraceptive?
Well, technically, yes, because the vast majority of patients would completely suppress their ovarian function. So it would completely suppress ovulation. But it does come back with a little bit of hormone replacement therapy. So they won't, they would say, look, very effective as a contraceptive, but they won't have the data about exactly how effective it is. So it can't be advised that that's what it can be used for. Mm-hmm. Much similar to other treatments we have like Copson or GnRH. We have to tell patients, look, technically this is not a contraceptive because there are no studies to show how effective it is, but it's a progesterone, and progesterone tablets are used as contraceptives. Lots of different progesterone tablets are, but technically this is not its prime use, and I don't have the data to say this is how effective it is. But much like Zoladex, it suppresses ovulation, it suppresses ovarian activity.
And I guess a bit of a disaster if you did happen to fall pregnant on it.
Yeah.
Thank you.
Well, I mean, if they found out they were pregnant on it, which is incredibly unlikely, then you would stop the medication, and most likely there's no long-term sequelae of that.
Right. Thank you. Sean, what are the roles that GPs can play in managing the long-term care of patients with endo, especially those who aren't planning to undergo surgery?
Yeah, so the GP really should be really important as the person that travels along the journey with this patient and helps facilitate their care from multiple different disciplines. So regular medication reviews for the patient, seeing if their symptoms are changing, look for other comorbidities as well. So if everything can't necessarily be attributed to endometriosis, or looking for other possible diagnoses as well. So do they have symptoms consistent with IBS? Other bladder pain issues as well, like interstitial cystitis. Does this need referral to a urologist? Facilitating multidisciplinary management, like referral to a women's health physio, referral to pain specialists, psychology, dietitians as well, but also championing self-management strategies. So there's some excellent resources online to help patients and GPs manage chronic pain and chronic pelvic pain in particular. So there's an Australian module called This Way Up, and they have a chronic pain module where it's free of charge for the patient if it's prescribed by the GP, and they have multiple modules where they'd catch up with the GP every couple of weeks and run through what they learned about chronic pelvic pain. And it's really a great strategy to manage different aspects of chronic pelvic pain, and the GP should be the centre of that, really. Coordinating other aspects of the patient's life as well, so contraceptive requirements related to their treatment, fertility planning, about whether you're talking about genetic screening with reproductive carrier screening, if they start to develop perimenopausal symptoms, tailoring their treatment to that as well. So yeah, there's definitely, the GP is for sure the most important medical professional for this patient to coordinate all of their care together from a lot of different teams.
Thanks, Sean. We're getting close to the end of the podcast, but you mentioned This Way Up, and I use that a lot, and I'll be putting a link to that on the Health Ed website as well so people can get to it easily. But are there any other websites or resources that you'd recommend to our listeners or their patients if they wanted to explore the treatment and the diagnosis and the sequelae of endometriosis further?
Yeah, for sure. So endometriosis in general, there's some great information on Endometriosis Australia. And Endometriosis Australia have a number of Facebook groups, and they're usually state specific. So in WA, we have Endo Warriors, and that's a nice support group for the patient. Often their main thing is they just feel unheard. So it's really nice for them to have other people who are in a similar situation that are going through what they're going through or are going through it at the same time. And that's a great support organisation. Other information, there's the Pelvic Pain Foundation, so pelvicpain.org.au has a lot of great information. Jean Hales Foundation has a lot of endometriosis and pelvic pain specific information as well. Endozone is a website that has really up-to-date information for clinicians as well as for patients about endometriosis. diagnosis, treatment, and management as well. Because there's a lot of information out there, and unfortunately there's a lot of incorrect information out there. So going to those known websites like Endometriosis Australia can be really fantastic for people to try and look at seeing other people that are affected by this condition, but also what their treatment options are as well.
Sean, I'll put links to all of those on the website as well. If I was to ask you, Sean, to list the most important messages that you'd really like to get out to our listeners today, what would they be?
I think the most important thing is having a really high index of suspicion for endometriosis as a cause for symptoms, and being proactive, because often someone won't come to you with the sole reason for their appointment being they suffer from dysmenorrhea or pain with intercourse. So I think use it as a screening question for all of your consults for anyone between menarche and menopause to say, do you have these common symptoms of endometriosis? And I understand time is a limitation, but even as like a screening tool that they could fill out in the waiting room before coming through. So really high index of suspicion. If you suspect they have endometriosis, don't hesitate to start empirical treatment, such as with the oral contraceptive pill or a Mirena IUD or anti-inflammatories, and have a low threshold to refer them on to a gynaecologist who specialises in endometriosis if they're not settling with those simple measures, or if they really have severe pain, or once you've arranged a pelvic ultrasound, which you could do after you've started that initial hormonal treatment if that shows signs of more severe disease as well. And I mean, there's a lot of information out there, but getting educated on the different non-specific symptoms of endometriosis and what the different treatment options are. But patients can usually have really good symptom relief with some fairly simple measures. So non-hormonal treatment, anti-inflammatories, hormonal treatment, some support from a women's health physio, some information on a low FODMAP diet, laparoscopic treatment done by an endometriosis specialist to optimise their pain outcomes as well, and the pain specialist if needed for managing ongoing pain.
Sean, thanks so much. It's been a fascinating update on all the current recommendations on endometriosis diagnosis and management. And thank you for sharing your time, your expertise, and your insights with us all today. You take care.
Thanks so much for having me. My pleasure.
Thank you for listening. Visit healthed.com.au to create a free account and claim CPD for podcasts like this and access a record of your learning. Subscribe to the show on Spotify or Apple Podcasts for weekly episodes on a range of clinical areas relevant to your ongoing practice.